Welcome to the Oncology Data Advisor podcast, where we explore the latest advances in medical research and treatment. This episode is provided by i3 Health. I am Katie Cook. Extrapulmonary neuroendocrine carcinomas are a heterogeneous group of tumors whose diagnosis is complicated by their diverse clinical presentations. Ongoing trials evaluating targeted therapies, immune checkpoint inhibitors, and radionuclide therapy are showing promise in treatment. In this podcast episode, Dr. Andrew E. Hendifar, Associate Professor of Medicine and Medical Director of Pancreatic Cancer at Samuel Ocean Comprehensive Cancer Center of Cedars-Sinai Medical Center, and Dr. Danielle Hutchings, Assistant Professor of Pathology and Laboratory Medicine at Cedars-Sinai Medical Center, will provide expert insights on diagnosis, treatment, and emerging targets in extrapulmonary neuroendocrine carcinomas. This activity is supported by an independent medical education grant from Boehringer Ingelheim Pharmaceuticals, Inc. Free CME, AAPA, and CPE credit are available for this podcast. To claim credit and obtain further information, including faculty disclosures, visit i3health.com/podcasts.
Hello, thanks for joining us. Today we'll be talking about clinical challenges in extrapulmonary neuroendocrine carcinomas, expert insights on diagnosis, treatment, and emerging targets. My name is Andrew Hendifar. I'm a medical oncologist at Cedars-Sinai Medical Center, and I'm joined by...
Hey there, my name's Danielle Hutchings. I'm a pathologist also at Cedars-Sinai Medical Center. All right, so we'll start off with our learning objectives. So the first one is to differentiate the clinical and pathological characteristics between neuroendocrine tumors, which we'll refer to as NETs, and neuroendocrine carcinomas, which we'll refer to as NECs. We'll talk about how to apply key diagnostic criteria for evaluating extrapulmonary NECs to minimize misdiagnosis and diagnostic delays and facilitate timely treatment. We'll outline evidence-based treatment strategies for patients with extrapulmonary NECs, including first-line therapies and how to approach progressive or relapse disease. And then we'll talk about the role of DLL3 as an emerging therapeutic target and its rationale for use. So first, we're going to start off with what are the key clinical, radiological, and pathological difference between NETs and NECs. So briefly, just to touch on terminology of neuroendocrine neoplasms, both neuroendocrine tumors and neuroendocrine carcinomas are epithelial neoplasms that show neuroendocrine differentiation. There are other neuroendocrine neoplasms which are non-epithelial in nature. Those include paragangliomas and pheochromocytomas, but today we'll be discussing epithelial neuroendocrine neoplasms. These tumors are classified based on differentiation and proliferation. So well-differentiated neuroendocrine tumors, those are graded into grades 1, 2, or 3, and that's based on the Ki-67 proliferation index or the mitotic counts. In contrast, poorly differentiated neuroendocrine carcinomas are high-grade, poorly differentiated tumors by definition. They are not graded based on the Ki. And the reason it's important to understand this distinction is that NETs and NECs are biologically distinct tumors. They show differing prognoses and treatment algorithms. And one other thing I just wanted to briefly touch on is the term carcinoid. So in pulmonary neuroendocrine tumors, those are referred to as typical or atypical carcinoid tumors. Carcinoid terminology is not typically used in extrapulmonary sites, although you will see it in older literature or even older pathology reports from when that terminology was in use. But now we call them well-differentiated neuroendocrine tumors or poorly differentiated neuroendocrine carcinomas. So just briefly to talk about the epidemiology of neuroendocrine carcinomas. So NECs of all sites occur at an incidence of about 9 per 100,000. Pulmonary NECs account for the vast majority of those cases, and they're most frequently small cell type. And we'll get into small cell and large cell type neuroendocrine carcinomas later on. But just a note that most pulmonary NECs are small cell type. And small cell neuroendocrine carcinoma of the lung has a very strong association with smoking. In contrast, extrapulmonary neuroendocrine carcinomas are relatively rare. So this figure came from a study of about 160,000 neuroendocrine carcinomas. You can see about 91% were of lung origin, whereas about 9% were extrapulmonary. Of those that are extrapulmonary, about a third were of GI origin. Another third were from other sites, most commonly the genitourinary or gynecologic tracts, and then about the other third were of unknown primary. So with that, I'll pass over the clinical features to Dr. Hendifar.
Okay, so neuroendocrine tumors and neuroendocrine carcinomas do have distinct clinical features as well. Neuroendocrine tumors tend to be incidentally discovered. You may or may not have symptoms related to hormone secretion, whether it's carcinoid syndrome from serotonin production, or even something like hypoglycemia from having an insulinoma. And neuroendocrine tumors, the patients have a prolonged clinical course. Now, in neuroendocrine carcinomas, typically they're diagnosed in the advanced setting, and the symptoms are more related to tumor compression, mass effect, pain, cachexia, etc. And neuroendocrine carcinomas are known to have an aggressive clinical course.
And just this image at the bottom shows you a typical looking neuroendocrine tumor. So here's the H&E morphology with this nested architecture and uniform cell population on the left. These center panels are neuroendocrine immunostains, synaptophysin and chromogranin. And then that last panel on the right is Ki67. You can see the Ki67 proliferation index is quite low, less than 3% in that one. On the bottom, here's an example of neuroendocrine carcinoma. So you can see we have these diffuse sheets of cells that lack any sort of architecture. The middle panels, again, are synaptophysin and chromogranin. Neuroendocrine carcinomas often have punctate or focal staining with neuroendocrine markers, whereas NETs usually have strong and diffuse staining. And then that panel on the right is the Ki. And you can see in neuroendocrine carcinoma, the Ki is typically very high, usually like 80–90%.
Okay, and you know, these tumors also have very distinct radiological features. So neuroendocrine tumors, especially when they're smaller or well circumscribed, they're hypervascular, and they're highly avid on the somatostatin receptor-based imaging, like a gallium-68, and they're typically negative on an FDG PET. Neuroendocrine carcinomas, on the other hand, they have more aggressive characteristics. They tend to be less well circumscribed. They're very highly avid on FDG PET, which is your normal PET scan, and they're typically very negative or weakly positive on a somatostatin receptor-based imaging or scintigraphy. So here you can see us on the spectrum, what you would expect to see on a well-differentiated neuroendocrine tumor on your left and a poorly differentiated neuroendocrine carcinoma on your right. On your left, you see tumors that are very clearly gallium-68 dotatate positive and FDG negative. And all the way on the right, you see FDG positive lesions that are all gallium-68 negative. Now, where you sometimes get a little difficulty is there are some tumors that will show some positivity on the gallium and some positivity on the FDG, and those tend to be tumors of more intermediate grade. But as you can see, using a gallium-68 and an FDG PET is a very powerful tool in helping you sort your patients' neuroendocrine neoplasms.
Great, so now we'll talk a little bit about the pathological classification of neuroendocrine neoplasms. So this is the WHO classification scheme for neuroendocrine neoplasms. So like we talked about in the well-differentiated neuroendocrine tumor, there's grade 1, 2, and 3, or low, intermediate, and high grade. And that's determined based on proliferation. So here you can see the cutoffs for the Ki67 index and mitotic count. each grade has distinct cutoffs. In the neuroendocrine carcinoma, again, this is a poorly differentiated tumor by definition. It can show either small cell or large cell morphology, definitionally high grade, and it always has a Ki over 20%. Usually it's much higher than 20%, but that's the minimum. This bottom one is called a NEN. It's a mixed neuroendocrine, non-neuroendocrine neoplasm. I don't think we're going to talk too much about that today, but basically that's a tumor where you have a distinctive neuroendocrine, either tumor or carcinoma component admixed with another tumor type. The most common one that we would see is an adenocarcinoma mixed with a neuroendocrine carcinoma. And again, those can show variable morphology and variable combinations. But just to be aware that that's another category of tumor that exists. So getting a little bit into the histomorphological features of neuroendocrine tumors. So neuroendocrine tumors and neuroendocrine carcinomas are typically readily distinguishable on histology. Neuroendocrine tumors show organoid architecture, and that just means that the cells show some organization. They're often grow in nests, which is pictured here. So you can see we have these cells clustered together, growing in this nested architecture. They can also show trabecula, cords, or even pseudoglandular architecture. The tumor cells themselves are very uniform. So you can see in this picture, a lot of the tumor cells look very similar to one another. And they have these round to ovoid nuclei. And then they have this finely stippled chromatin. So you can see in the nucleus, there's these little dots, and we refer to that as salt and pepper chromatin. And that's very characteristic of an NET. They can have cytoplasmic granules. So here in this picture, you can see we have these reddish, fine cytoplasmic granules. Those are often prominent in midgut NETs. NETs, necrosis is very rare, and these tumors are often strongly vascularized, and they'll have small capillaries in close contact with tumor cells. Here's an example of how you would grade an NET by Ki67. So grade 1 tumors have a Ki of less than 3%. So here you can see Ki is staining only a few nuclei in this whole field of tumor cells. So that's well under 3%. Here's an example of a grade 2 neuroendocrine tumor. So those have KIs between 3 and 20%. So you can see the brown staining in these nuclei within that range. And then here's an example of a grade 3 NET. So they have KIs greater than 20%. So you can see that there are many more nuclei that are staining brown compared to these lower grade tumors. So for NECs, I'll show some pictures in the next few slides, but generally speaking, they lose that organoid architecture. So they're going to be growing in diffuse or sheet-like arrangement, although you can sometimes have larger irregular nests. Necrosis is a common finding. They typically lack that characteristic salt and pepper chromatin. There's usually abundant mitotic figures or apoptotic debris. And then NECs can be classified into small cell and large cell types. Interestingly, there is some correlation with the small cell and large cell morphology with site of origin. So lung NECs are much more commonly show small cell morphology, whereas gastrointestinal NECs, the proportion that shows small cell morphology is much less. They typically show large cell or more ambiguous morphology. Here's an example of small cell carcinoma. So you can see we have this, very cellular tumor. It looks quite blue. The cells do not have a lot of cytoplasm, and it's composed of these small to intermediate sized cells. They typically have a high nuclear to cytoplasmic ratio. They may show nuclear molding. Again, they're going to have finely granular chromatin in contrast to that salt and pepper chromatin. Usually nuclei are inconspicuous. Biopsies often show crush artifact, and then mitoses and apoptotic debris are typically prominent. And so here's an example of Ki67 in a small cell carcinoma. It's almost always very high, so about 90% at least in this image. Large cell type neuroendocrine carcinoma, that can show more variable morphology, but often it's composed of larger, relatively uniform cells with amphiphilic cytoplasm, and they often have large nuclei with fascicular chromatin, and they may or may not have prominent nucleoli. So in this image, this pink debris is all necrosis, and then we have abundant mitotic figures. In contrast to the other one, you can see we have more abundant cytoplasm, and then these nuclei with this vesicular chromatin. And then here's an example of synaptophysin and chromogranin immunostaining in this large cell NEC. They are positive, but you can see specifically on the chromogranin A, there's some kind of punctate paranuclear staining, which is a common feature that you'll see in neuroendocrine carcinomas. And I just briefly wanted to talk about Merkel cell carcinoma. So that's essentially small cell carcinoma of the skin. It's morphologically identical to neuroendocrine carcinoma arising from visceral organs. There are some things you can do to tell apart the site of origin. So obviously, if the patient has a clinical history of a cutaneous lesion or an active cutaneous lesion, that could suggest Merkel cell carcinoma. Certain immunohistochemical stains are typically positive in Merkel cell carcinoma. Those include cytokeratin 20, neurofilament, and SAP-B2. And TTF1 immunostain is typically negative in Merkel cell carcinoma, and that's going to be positive in a significant subset of neuroendocrine carcinomas, even those of extrapulmonary origin. Merkel cell carcinomas can be driven by Merkel cell polyomavirus, and there's actually a stain that we can do to look for Merkel cell polyomavirus. So that's another helpful feature. And cases that are polyomavirus negative can show UV mutational signature. So if you were to do NGS and you had a UV signature, it would suggest that it was Merkel cell carcinoma rather than small cell of visceral origin. Okay, so moving on to the next topic. So what diagnostic criteria must be considered when evaluating these tumors, and how do they influence treatment decisions? So in terms of pathology, the diagnostic criteria for extrapulmonary NECs, so it's a poorly differentiated neoplasm with epithelial differentiation. And that means you have to have positivity for cytokeratins on immunohistochemistry. And just of note that positivity can be focal or paranuclear dot-like. So sometimes you may have to kind of hunt around to find that positivity. But neuroendocrine carcinomas are epithelial neoplasms and should demonstrate keratin positivity. Morphologically, they can show small, intermediate, or large cells, as we saw in those pictures before. And they should show expression of 2 or more neuroendocrine markers by immunohistochemistry. So neuroendocrine markers include synaptophysin, chromogranin A, and or INSM1. We try to avoid using CD56. This is an older stain, and it's still in use by some pathologists, but it's really sort of the least specific neuroendocrine marker and can be positive in a variety of non-neuroendocrine tumors. And so we generally try and avoid using CD56 whenever possible. Of note, as we saw in some of those pictures, the neuroendocrine markers can sometimes be focal or show dot-like positivity. So as the pathologist, we really have to kind of hunt around to find that staining. And again, the Ki is always going to be greater than 20%. Typically, it's going to be well above that, even up in the range of greater than like 70%. All right, so now I'll pass it over to Dr. Hendifar to discuss some treatment options.
Okay, so not only, as Dr. Hutchings described, the pathology and the radiologic characteristics are very different between these tumors and the carcinomas. Here we're going to talk about treatment options. They're really diametrically opposed. So for well-differentiated neuroendocrine tumors, we frequently use surgery and cytoreductive techniques like liver-directed therapy. And if they have certain somatostatin receptor expression, they'll get somatostatin analog therapy, radioligand therapy with lutetium-177, oral tyrosine kinase inhibitors like cabozantinib, mTOR inhibitors like everolimus. On the other end, in poorly differentiated neuroendocrine carcinomas, really it's chemotherapy and immunotherapy in rare cases, and a lot of focus on clinical trials and new therapeutic development, and specifically in T-cell engagers and those targeting DLL3.
So I think we'll talk more about that treatment in a little bit, but right now we're going to talk about some of the common diagnostic pitfalls for extrapulmonary NECs and how collaboration could improve diagnostic accuracy. So one of the major challenges can be distinguishing that grade 3 well-differentiated neuroendocrine tumor from a poorly differentiated neuroendocrine carcinoma. As we discussed, the difference is really usually morphologically apparent, so they're usually morphologically distinct. However, some tumors can show ambiguous morphology. And that can be particularly true on a small biopsy specimen. So if you're looking at a core biopsy or even an FNA, a fine needle aspiration of a tumor, we often have less material to work with. And so it can be more difficult to appreciate some of the morphologic features in those small specimens. So in cases that are difficult to distinguish morphologically, there is some additional immunohistochemical and molecular profiling that can be helpful to differentiate between these two. And we'll get to that in a second. Other things that can help is correlation with the somatostatin receptor-based imaging, or FDG PET. As we saw a few slides ago, that can be really helpful to distinguish in certain cases. And then correlation with the clinical pace of growth. So is it a small tumor, or a tumor that's been sitting around for a few years, growing very slowly, or is it a large, aggressive, rapidly progressive tumor? So here's sort of a panel of immunohistochemistry and molecular profiling that can be helpful in this differential of grade 3 NET versus NEC. And I just want to say that pretty much no one of these markers is going to give you the answer. And so it's really important to evaluate as many of these markers as is possible in your lab, as well as correlate with the clinical features, the imaging, because it's kind of you kind of have to synthesize each one of these different factors and sort of make sure it makes sense in the overall picture. So one thing that's helpful is Ki-67. So grade 3 NETs typically have lower KIs. Some people have used a cutoff of 55%. It's not absolute. So a grade 3 NET can have a KI greater than 55, and NEC could have a KI less than 55. But generally speaking, if you have a very high KI, you're more likely in the NEC category. And if you have a high, but not sky high KI, you're sort of in the grade 3 NET realm. RB loss can be really helpful. So RB is intact in grade 3 NETs, and it can be lost in neuroendocrine carcinomas. P53 is another helpful marker. So it's typically shows intact staining, which is basically, so we use P53 as a surrogate for TP53 molecular alterations. So when we have wild type P53 staining and a G3 NET, whereas in NEC, you typically have a mutant pattern. And there's a couple different patterns. You can have either strong, diffuse overexpression pattern, or complete loss of expression or null pattern. P16 is typically patchy, weak to moderate in grade 3 NETs, whereas it can be strong and diffuse in NECs. Somatostatin receptor type 2, and this correlates well with the imaging, somatostatin receptor-based imaging. But grade 3 NETs typically have strong and diffuse immunostaining with somatostatin receptor type 2, whereas NECs may be negative, or they have sort of more patchy, weak to moderate staining. TTF1 is usually negative in grade 3 NETs, and it can be positive in about 40% of extrapulmonary NECs. If TTF1 is negative, it's not really helpful, but if it is positive, that can help support the diagnosis of NEC. And then depending on what site of origin you're dealing with, there can be a few additional helpful markers. So pancreatic NETs, they're pretty well characterized molecularly, but they can have loss of DAX, ATRX, menin, or P27. And so there are some stains that we can do to assess for these molecular alterations. And so if you had a tumor with loss of DAX or ATRX, that would help support the diagnosis of grade 3 NET. Some markers that have sort of been researched more recently. So we'll talk more later about DLL3, but there's been a few studies where it's been more often positive in neuroendocrine carcinomas, whereas it's been more negative in grade 3 NETs. And then CXCR4, there's been studies where that's been mostly negative in grade 3 NETs and positive in NECs. So we haven't really used these for diagnosis yet, but that may be something that we may add to this panel in the future. So here's a couple examples of what that might look like. So this would be an example of a grade 3 pancreatic NET. So in our first panel, we have an H&E. This is a biopsy specimen, so it's difficult to tell the histomorphology in this specimen. I see these sort of detached clusters of cells. They're not wildly atypical, but they're not exactly completely uniform either. Here's the Ki-67. It's elevated above 20%. It's probably about 40%. So, it's high, not quite as high as typically seen in an NEC, but definitely high for an NET. Here's a somatostatin receptor type 2 immunostain, and you can see it's strongly and diffusely positive. Here's RB1 immunostain. You can see it shows intact nuclear staining. P53 shows a wild type pattern where you have variable intensity nuclear staining in the tumor cells. And then here's ATRX, which is completely negative. So this is consistent with loss of ATRX. So this would be a panel of stains that would support the diagnosis of a grade 3 pancreatic NET. On the other hand, here's an example of these additional studies in an NEC. So in the first panel, we have an H&E image showing diffuse sheets of cells. There's a focus of necrosis. The Ki-67 in the next panel is very high, 80 to 90%. Here's the chromogranin, which again shows that dot-like positivity. And then the RB stain shows loss. So these tumor nuclei are negative, whereas we have some internal control non-neoplastic cells that are staining positive. The TTF1 is positive and ATRX is intact. So this panel of stains supports the diagnosis of neuroendocrine carcinoma.
Thank you, Dr. Hutchings. So I'm going to be talking about the current first-line treatment options for extrapulmonary neuroendocrine carcinomas and maybe touch upon how they differ from those with neuroendocrine tumors. Okay, so the first-line treatment for patients with neuroendocrine carcinomas is the standard platinum etoposide, kind of similar to the small cell lung cancer paradigm, but the use of immune therapy is not really on label for extrapulmonary neuroendocrine carcinomas. Alternative approaches include using a platinum with irinotecan. For second line, predominantly one uses either FOLFIRI or FOLFOX or temozolomide based, although there's limited evidence. Immunotherapy, unfortunately, has modest activity. You could consider if you had other biomarkers supporting its use. And the key difference that I'd like to emphasize is that neuroendocrine carcinomas, there is no role for somatostatin analog therapy or peptide receptor radiotherapy. Those simply have no activity and will not be of benefit. For well-differentiated neuroendocrine tumors, the first-line therapy is somatostatin analog therapy, and upon progression, it would be radioligand therapy, such as lutetium-177 dotatate. Afterwards, there's also targeted therapy, whether it's targeting mTOR pathway with everolimus or using VEGF TKIs such as sunitinib and cabozantinib. Chemotherapy is infrequently used and pretty much relegated to pancreatic neuroendocrine tumors with the use of capecitabine and temozolomide. Now, I'm always asked about sequencing in the treatment of neuroendocrine neoplasms. And neuroendocrine carcinomas, it's actually a little bit more straightforward. Now, a lot of clinicians and experts will recommend rebiopsy and confirming histology. I find that sometimes useful, but more importantly is to get the original specimen reviewed to make sure that you have more than one pathologist agreeing with the diagnosis. It's always important to reconsider your approach and looking at the Ki-67 and other biomarkers that might select for a particular treatment. And also it's important to look at how long did they benefit from the previous platinum and what kind of performance status are we thinking about right now. Now, after platinum failure, either we use irinotecan or fluoropyrimidine, which is part of the ENET's guidance for this. You can use FOLFOX, which is combining 5-fluorouracil with another platinum agent. CAPTEM, although in my practice, I tend to use this specifically in patients with pancreatic neuroendocrine tumors. Although in patients with neuroendocrine carcinomas, this is sometimes used. Sometimes we borrow from the small cell lung cancer literature and use things such as topotecan or other taxanes or topoisomerase inhibitors. And we try to do our best to enroll in clinical trials with either novel targeted agents, antibody drug conjugates, and other combinations with anti-angiogenic medications. And, some could consider using bevacizumab and FOLFIRI based on the EP-NEC data from PRODIGE investigators. When selecting second-line treatment, really, it should be an individualized decision. It should be based on the comorbidities, the prior toxicities, and how rapidly the patient's progressing. Always want to sequence to non-cross-resistant agents when possible. I think early referral for clinical trials is essential. And there's very limited high-level evidence for the second-line treatment in extrapulmonary neuroendocrine carcinomas. Also, if a patient's having significant pain, usually from bone metastasis, which is not an uncommon problem, definitely consultation to palliative care and to radiation oncology for local therapies such as radiation for symptomatic benefit. So now I want to talk a little bit about DLL3 in neuroendocrine carcinoma. So delta-like ligand is a transmembrane protein, and it's an inhibitory ligand of the Notch receptor pathway. It's upregulated in neuroendocrine neoplasms, especially those that are poorly differentiated, and promisingly, it's minimally expressed in normal tissues, which makes it a great target for cellular therapies. Now, in preclinical models, DLL3-directed agents, including antibody drug conjugates, bispecific T-cell engagers, and CAR-T, definitely have a lot of activity, causing potent tumor killing in DLL3-positive neuroendocrine tumor models. And the translational studies also support this, but one issue of concern is the heterogeneity in DLL3 expression. And so that's one of the big biomarker challenges, is making sure that the biomarker that you're sampling is representative of the entire specimen, of the entire disease. One of the benefits of targeting, or the idea of targeting DLL3 in neuroendocrine neoplasms, is again that it's frequently expressed in the poorly differentiated cancers, and there's limited expression in normal tissue. There's a very high prevalence of small cell lung cancer, and the substantial subset of the extrapulmonary neuroendocrine carcinomas do have very high DLL3 expression, which can be easily detected by IHC. Now, Rova-T was an earlier antibody drug conjugate that was developed for DLL3. I actually participated in that clinical trial, but it wasn't potent enough and it wasn't show benefit in a phase 3 trial. However, tarlatamab is a DLL3 targeting bispecific T-cell engager, which recently received FDA approval for the treatment of relapsed small cell lung cancer. And here you see the pivotal trial where tarlatamab was compared to standard chemotherapy of choice in the second line. And here you see an improvement in overall survival, a significant improvement in overall survival with a hazard ratio of 0.6, which led to its FDA approval in this disease. So as you can see, both in preclinical and clinical studies, DLL3 is a rational and promising target in neuroendocrine carcinoma with a clear biological basis and a very easily to measure biomarker. Now, because of the history with Rova-T being negative, you can see that probably the bispecific T-cell engager is a more promising approach. And going forward, the challenge for clinicians is to really better understand which neuroendocrine neoplasms have DLL3 expression and consideration of referral for clinical trials. And the key clinical trials that are currently in development include tarlatamab, Obrextamig, and other DLL3 studies, targeting studies. Okay, so now we're going to talk a little bit about the challenges and limitations of targeting DLL3 and how that might be addressed in clinical practice. So DLL3 is highly expressed in small cell lung cancer, and because of that, we have an approval by the FDA for tarlatamab, and we have to understand exactly what is the expression in neuroendocrine carcinoma similar or more variable. We have to think about whether or not expression is cytoplasmic or membrane, and try to get a better understanding how target availability can impact response. Now, an additional challenge is resistance mechanisms. These are not fully understood. So it's unclear if resistance is via antigen downregulation, cellular selection, tumor microenvironment adaptation, or tumor heterogeneity. And unfortunately, in neuroendocrine carcinomas, there can be rapid disease progression and recurrence. Now, safety and toxicity, again, Rova-T failed due to efficacy concerns and a poor safety profile. But other T-cell engagers in development do have cytokine release syndrome as a notable risk factor, neurotoxicity, and infusion reactions. But with our use and experience with T-cell engagers, our ability to manage the toxicities are improving considerably. Now, what are some of the barriers to delivering these types of therapies? CAR T and T-cell engagers, they do face delivery challenges. We think of poor tumor penetration, maybe a desmoplasia as being an issue. We're concerned about, on target, but off tumor, which is when, for example, a normal tissue will express the antibody. Fortunately, DLL3 is not typically expressed in normal tissue. And also, we're concerned about the efficacy of using cellular therapy in solid tumors. We have dozens and dozens of approvals of cellular therapy in the hematologic space, but in the solid tumors, we haven't been as successful. So let's talk about, generally speaking, what are the promising targets or therapies that are being developed for neuroendocrine carcinomas, and what are the key clinical trials to watch? So, of course, targeting DLL3 for both bispecific T-cell engagers as well as antibody-drug conjugates is probably the most promising and most popular clinical trial development pathway. But there are also concepts for somatostatin receptor expressing disease. Lutetium dotatate 177 has been approved and well differentiated in low-grade neuroendocrine tumors, but now it's being developed more in intermediate grade and sometimes looked at in more high-grade disease. And DNA damage response medications for HRD tumors, including PARP inhibitors with or without immune therapy, or in combination with PRRT. So let's look a little bit more closely into this. So for DLL3 targeting bispecifics, drug conjugates, and T-cell engagers, we have tarlatamab, which is currently in phase 2 basket trials, and Obrextamig, which already has early data in DLL3 positive small cell lung cancer and neuroendocrine carcinoma, which we'll talk about, using PARP inhibitors and PD-1 combinations, such as niraparib and dostarlimab, have cohorts that include high-grade neuroendocrine carcinomas, looking at expanding the diseases appropriate to receive PRRT with radiosensitizers such as olaparib are being investigated. And there's also chemo optimization, looking at novel cytotoxic approaches such as modified FOLFIRINOX and TAS-102. So here, I wanted to show you a waterfall plot of Obrextamig, which again is a bispecific T-cell engager. 168 patients were enrolled in a clinical trial that included both neuroendocrine carcinomas, small cell lung cancer, and large cell lung cancer. Now, the maximum tolerated dose was not reached, and grade 3 CRS occurred in 3% of the patients. But as you can see here, there was promising activity with a response rate of 23%. The duration of response was 8.5 months, and the activity was consistent across all these cohorts that expressed DLL3. Here we have a Swimmer's plot showing us that the responses were quite durable. So how do we proceed now with this known activity in patients with DLL3 expressing neuroendocrine carcinomas? Well, if you can, you want to test the tissue locally for DLL3 or enroll them into a clinical trial looking at DLL3-based therapies where an IHC-based test will always be used as a screening parameter to assess whether they're eligible. Also want to make sure that the patient doesn't have another actionable alteration or a different treatment approach that would be appropriate. DLL3 positive neuroendocrine carcinomas very infrequently will have targetable fusions or alterations in other pathways. So definitely always check. You can use a gallium-68 to identify SSTR positive disease. But again, from my experience, neuroendocrine carcinomas would not benefit from these types of approaches, except if you're doing it on the clinical trial. I definitely recommend referring these patients as soon as you encounter them for clinical trial evaluation, as the standard therapy are not very effective. Do suggest that patients receive platinum etoposide as a first-line treatment, but that on progression, they're considered for clinical trials. So what are the most significant unmet needs in the management of extrapulmonary neuroendocrine carcinomas, and what steps can we take as a community to improve patient outcomes? So, in the community, it is very hard to take care of these types of patients. I think the hardest thing to do is, the pathologists who might see the tumor in the community might not have the luxury of seeing lots of cases. So you might not have all the information that you would ideally want. So definitely we see inconsistent Ki-67 reporting and different IHC panels used at different sites. We do also have heterogeneity between, for example, the primary site and the liver metastases. So these are things that we kind of have to get over, I guess, or to better accept when we're dealing with these patients. Usually in our practice, if somebody has a liver met with a higher Ki-67, then we would tend to, use the higher grading as the consideration for therapeutics treatment selection. A huge other problem in neuroendocrine carcinomas, besides the pathologic criteria and the diagnostic issues, are that the response to first-line systemic treatment is short-lived. And and there's really isn't any site-specific approaches. For example, a pancreatic neuroendocrine carcinoma will be treated similarly to a large bowel neuroendocrine carcinoma with carboetoposide, and we really don't have specific treatments on sites other than small cell lung cancer. Again, with no established second-line treatment, this is although it's a difficult thing for the patient, it does become a situation where they can enroll in clinical trials. Immune therapy has been used based on small phase 2 trials, but the activity is inconsistent across studies, and there's no clear biomarker to help with patient selection. I mean, other issues are that there are few prospective multi-center randomized trials to help us in second line, and the translational models used to date are typically underused for drug discovery. And outside of DLL3, we don't have a lot of new treatment approaches being developed for these tumors. Yeah, so I mean, if I'm in the community and I'm seeing a patient with a neuroendocrine carcinoma, sometimes it would be helpful to get a second opinion if that would be useful. We as a community need to develop registries and biobanks to help with biomarker selection so that we can do more biomarker-driven trials like DLL3. We have to do more multi-center approaches. And as always, multidisciplinary care and palliative integration are key. So on behalf of Dr. Hutchings, I'd like to thank you for your attention.
Great,
Thank you.
thanks.
Thank you for listening to the Oncology Data Advisor podcast. If you haven't already, be sure to subscribe so you'll never miss an episode. To claim CME, AAPA, or CPE credit for this activity, visit i3health.com/podcasts. You'll also find plenty of other free educational resources and offerings. And don't forget to connect with us on social media for free CE activities, news, exclusive interviews, and more.